So now let us talk about primary angle closure glaucoma. When you say angle closure, now you all have very clear concept. It's a peripheral space between iris and cornea. Think yourself, when will this space is going to be? I'm drawing again in front of you. So this is what is your angle, right? This is the angle. The space between iris behind and cornea above it. So do you realize when is this space going to be occluded most? In which position of the pupil? Is it constricted or dilated? Definitely dilated, isn't it? So when the pupil is dilated, there is bunching of iris at the periphery that is actually causing the blockage. So one thing that you have to keep in mind is position of the pupil. Maximum closure, put it in the box, of angle will occur in mid-dilated pupil. So generally it is seen that the maximum closure occurs in a mid-dilated pupil. Okay, so what are the risk factors? Because it's a primary angle closure we are discussing, we do not know the exact cause, it's primary. So we will be learning what are the risk factors for primary angle closure glaucoma. Think yourself, common sense. When is this space between the iris and cornea more prone for closure? Number one, small eye, isn't it? So hypermetropia or small eye. Particularly, let us also mention more when the eye is very small, like less than 21 is microphthalmos and less than 20 is nanophthalmos. So very, very common in nanophthalmos. Nanophthalmos is less than 20 mm of axial length. Right? So this is one risk factor. Naturally, if the eye is small, we are talking about shallow AC, narrow angles. So this is one important risk factor. What is the second? It is more common in females. So number two, it is more common in females. Is there any family history? So it is seen in families where if one person is affected, it is seen that the other family members may be affected, but the genetic loci has not been very well defined. Okay, it's a poorly defined factor. So we can say that more prevalent in family. So family history, we will say it is more prevalent in one family, not in a family. Okay. Then we talk about, but generally as we had learned for open angle about myocilin, optinurin, we are saying that we cannot define the exact gene. Right? Okay. Very, very important risk factor is increased lens vault. Now what is this lens vault? Right? So lens vault is nothing but part of the lens which is just anterior to the angle of anterior chamber. So we'll talk about this more when I show you the slides. Just note down increased lens vault. Vault means the part of lens anterior to anterior chamber angle. AC angle, anterior chamber angle. Okay. What could be the next risk factor? Let us not forget plateau iris. If there is a plateau, we will talk in detail today about plateau iris. If there is a plateau iris, this is again a very big factor for angle closure glaucoma. Once we know the risk factors, we will now discuss the mechanism of angle closure glaucoma. What are the two main mechanisms? You have written in your classification also, it can be with pupillary block or it may not be with pupillary block. Without pupillary block, we are mainly talking about plateau iris, or it could be even a combined, both mechanisms are working together. So if I talk about mechanisms, draw 3 lines and we will write with pupillary block or without pupillary block. Generally we are talking about plateau iris, or it could be combined mechanisms. Both factors are working. Done? Okay. So let us take one by one. First we are talking about that what is the mechanism when we say with pupillary block. So I think it's absolutely very, very simple. I'll show you the slide, but let's first think ourselves. So what is happening? Any relative pupillary block here. So many times we have discussed it, I think earlier also. That means the aqueous cannot flow anteriorly. Where will it get collected? Of course, it is collected here. So when the aqueous is collected here, it is going to, there is block, no aqueous can flow anteriorly. It is collected here, it causes iris bombae. And this is the reason why angle gets blocked. Let's see this. Let us have a look at this one. So this is what it is showing, that whenever there is a pupillary block here, there is a collection of fluid and iris bombae bowing of iris forward, which is blocking this angle. Right? What is angle? Peripheral space between iris and cornea. So this is with pupillary block. So when there is a pupillary block and iris bombae, that can cause one. This is one factor. Okay, let's see this slide before that. So this slide is showing you the lens vault, anterior lens vault. What is anterior lens vault? Can we see this? This part of the lens shown here, which is just anterior to the angle of anterior chamber, is called a vault. If it is big, it will cause a pupillary block. So the pupillary block that you have been talking about, if I want to think, okay, what can be the causes of this pupillary block? It is generally either increased lens vault, or it could be due to increased lens thickness. We learned about phacomorphic glaucoma. Again, that was a pupillary block, right? So this is just these are the factors, right? Then we were talking about if this convexity, can you appreciate this is anterior iris convexity that is being seen here, and then what it is showing, because of the anterior lens vault is too much, there is a convexity, there is iridocorneal apposition. So this whole slide is explaining you how an increased lens vault can actually lead to apposition like this, right? Okay, so how are we looking? What is this exactly? So there are two main investigations where details of the angle can be very nicely seen. One is ultrasound by microscopy and another is anterior segment OCT. So you are looking here at anterior segment OCT. How do we make out which is which? I'll just tell you later. So this is again telling you how this is iris bombae is actually because of the pupillary block and iris bombae, how there is a iridocorneal touch. It is all, I think it is self-explanatory here. Again, this is a detailed, this is the iris, the detailed structures, the structures of the angle, which is seen very nicely here. So if this is the cornea, this is the iris. What is this? This whole thing is the angle. Anteriormost part of the structure in the angle would be Descemet's membrane of the cornea, and this is what is called your Schwalbe's line. It is nothing but Descemet's membrane of cornea, right? And you can see a part of the sclera here. This is the angle recess, this is the scleral spur. It's just a part of sclera, white part seen, we call it scleral spur. We'll talk about details of the angle again shortly in gonioscopy. Let us see the plateau iris. Now you are looking at this type of the alignment of the iris, which is more flatter. That is what is called plateau iris. Why this has happened? It has happened because there has been this is your anteriorly rotated, this is the normal. Normal is this one. This is pars plicata. This is the anterior lens capsule, posterior chamber, iris. This is the Schwalbe's line. Again, this is ultrasound by microscopy showing you Schwalbe's line, anterior chamber, iris. This is posterior chamber. In the angle, I can appreciate the scleral spur. This whole is pars plana. So you have to be first very clear about the anatomy. Now we are saying plateau iris is anteriorly rotated ciliary. So when there is any rotation out here, what will it do? It will make the iris little, it will push the iris anteriorly and it becomes more flatter. So you will see it is the periphery of the distance of the anterior chamber depth is very less, not the central. So when you look here, this is now the iridociliary contact. Because of the anteriorly rotated, this is anteriorly rotated ciliary body leading to contact with the iris, which was not appreciated here. Look here, this is a gap. Here there is a contact. Because of that, it has made the iris more flatter. Right? This is what is plateau iris. So what will happen if it is like this? It is more prone to be prone to angle closure by obliterating this space later on. Okay. So this is what is plateau iris. So can we write it now if we have understood? So how to differentiate generally when you are seeing the structures behind with this is ultrasound by microscopy. Okay, if you cannot see the structures behind the iris like this as we see in this AS OCT. This is the anterior segment OCT. We'll write this also. It was just a quick glance. so that you can understand. So we know what is pupillary block and why a pupillary block can occur. Now we also know what is plateau iris. Anteriorly rotated ciliary body making the iris plane flatter is plateau iris, and typical of plateau iris is peripheral anterior chamber is shallow and central anterior chamber is deep. If you want to note down, just note down. And remember, when you're talking about plateau iris, there is no contribution of lens, or there is no lens component which is contributing to angle closure. Right. Okay, so next we will learn is how to assess the anterior chamber angle. Right. What are the investigations I can do to know the status of the angle? Is it occludable angle or is it an open angle? So what are the investigations? Right. So it's all in front of you, and this is we will just list it. We have listed out here. First is gonioscopy. We will learn what is Van Herrick method, what is the Schaffer system of grading the gonioscopic finding, and I have already mentioned you about the ultrasound by microscopy. Just remember, if I have to see posteriorly, I will use 10 megahertz, but because I have to see the anterior segment, I am using 50 megahertz for this. And anterior segment optical coherence tomography, which is a non-contact method. As I told you how to differentiate, in AS-OCT, we are not able to see structures behind the iris, but in UBM, we will be able to see. One by one we will take. First we will talk about gonioscopy. What is gonioscopy, everyone? It is bimicroscopic visualization of the angle of anterior chamber. So this is what you are looking here. The examiner is seeing through the slit lamp, and this is the gonioscope in his hand, which he has put in the patient's eye, and looking through it he is able to see the angle structures. What are the angle structures that the examiner can look at? So what are the angle structures we have to think that? How do you learn it? Sometimes you people find it very difficult. It's very, very simple. Let's see here. If this is your cornea and this is your iris, common sense, posteriormost is iris, anteriormost is the cornea. Which part of the cornea? Descemet's membrane, which is called Schwalbe's line. So here you have anteriormost structure. So this is how you see when you're looking at the gonioscope. You see these lines. You know this is the part of the cornea. This is Schwalbe's line. Right? And after that we talk about non-pigmented trabecular meshwork and pigmented trabecular meshwork. Once we know this, then comes your scleral spur, that is part of sclera, ciliary body band, and then this is the iris. Right? So, from anterior to posterior. Right? What are the structures? Let us learn together. First is Schwalbe's line. Right? Non-pigmented trabecular meshwork, pigmented trabecular meshwork, scleral spur. You just saw it in this AS-OCT slide, what is scleral spur. After scleral spur, when you were seeing the plateau iris slide, if you remember that structure through your slide, you don't need any mnemonic to learn it at all. You don't need a mnemonic. You will just understand if you're clear with the picture of the anterior chamber angle. So it was Schwalbe's line. Definitely there has to be trabecular meshwork first, non-pigmented and then pigmented. We saw the angle recess and the scleral spur, and then we saw the ciliary body band, and then comes the iris. So ciliary body band and then the iris. Right? So these are the structures I am going to see. If I can see all these structures, the angle is open. But suppose we cannot see post-trabecular meshwork. So if after pigmented I am not able to see scleral spur, ciliary body band, right? These structures are not visible. So if the post-trabecular structures are not visible in more than 180 degree, angle is all 360 degree, I hope you are clear. So in more than 180 degree, then these are called occludable angles. Means there is a risk that this is going to occlude and this patient is in a high risk of angle closure glaucoma. Got it? Do you want to write down what are occludable angles? Occludable angles means when the structures that you are seeing is more than 180 degree post-trabecular posterior, that means post-trabecular, posterior trabecular, not seen. Right? On gonioscopy. This is what is called occludable angle. Let us talk about, when we are going to discuss the grading, you will be more clear about what structure is seen, what not, and how much it is open. Let's wait for that. Another, I am reminded of few exam questions here. They have asked you, the question was, which of the following investigation does not require dilatation of pupil? And the 4 options were given where the answer would be, so whenever you have to see the angle, whenever you have to operate on the angle, any procedure in the angle, you want the pupil constricted. I started my topic explaining you that when the pupil is constricted, then only you can, angle is open, and if it is an occludable, so whenever the pupil is dilating, there is a bunching of iris at the periphery which is leading to angle closure. Okay? So this is very important. So gonioscopy will not need a dilatation. This is exam question. Does not need dilatation of pupil. Right? Okay. Little bit more about gonioscopy. So why am I doing a gonioscopy, all of you? I told you that through slit lamp we can see the whole anterior segment. If I can see the whole anterior segment, what is the big issue about the angle? Why do I need something separate for seeing this angle and the structures in the angle? So that we will understand if we a quick revision about a little bit of physics here about what is critical angle and what is total internal reflection. So if you remember your optics chapter, you must have read it in your 11th, 12th also. So whenever the light ray is passing from denser to the lighter medium, refraction is what? It is the deviation of the light rays. So it deviates away from the normal, isn't it? Have you all learned this? So whenever the light is going from the denser medium to the lighter medium, it will deviate away. Please make this diagram for yourself, you will be clear here. I am making it here only. Right? If this is the denser and this is the lighter medium, this one is the normal. If suppose the light ray comes from, so we are talking about denser to the lighter medium. So if it has, this is the angle of incidence, and when it goes away from normal, that becomes the angle of refraction. You have learned this? Refraction mein I upon R is equal to mu, right? So it can be lighter to denser, denser to lighter. If it is coming like this is the angle of incidence, and this can be towards, if this is lighter, this is denser, this can be towards the normal, this will be the angle of refraction. And ratio of I upon R is mu. Anyway, we are not talking about mu here, we are trying to understand that if you keep increasing this angle of incidence, look here, that angle of incidence where when this refracted ray is 90 degree to the normal, which means that above this angle of incidence, it is not going to refract and there will be total internal reflection like this. If I is, angle of incidence become greater than this angle, which is critical angle, and there will be total internal reflection. Okay, if you have revised this, you have kept in mind, so this is what is critical angle, when the refracted ray is 90 degree to the normal. What happens in your eye is the same thing. First of all, it reminds me exam question, I'll forget, so write it down. What is the critical angle of cornea? This was your exam question, and the answer is 46 degrees. Okay? Acha, अब what is happening is whenever, look here, so what is happening in your eye is I am not able to see the angle structure through the slit lamp because there is total internal reflection inside the anterior chamber. Okay? Now what happens? To avoid this, what we can do, we can change the density of the medium, the refractive index of the medium by using a gonio lens. Right? For air it is 1 and for aqueous humor it was 1.33. So it was from more denser to lighter. Now you are putting a gonio lens. It can be 1.39 also, 38, 1.5, whatever may be the index of the gonio lens. So now this one becomes denser and this becomes lighter. Then there is no total internal reflection, and what happens here, there is a mirror here. So the light that is traveling from the angle is first hitting on the mirror, reflected from the mirror, and then you are able to see. It could be direct also. I can directly visualize, but just understand the principle of gonioscopy. This can be asked. I am quickly telling you, 46 degree is the critical angle. Any angle of incidence, if it is equal to critical angle, then the refracted ray is 90 degree to the normal. But if it is more than that, there will be total internal reflection. If there is a total internal reflection, In that case, I am not able to see the angle structures because of this process happening. Therefore, I use a gonio lens which has a more refractive index, therefore no total internal reflection and hence visualization of the angle. Okay, so this can be asked. Now these gonio lens, am I looking through the reflected mirror or I am looking directly? Accordingly can be of two types. It can be either indirect lenses where I am using a mirror and from the reflected light I am seeing this. And what are the name of these indirect lenses is in front of you. Please note it down. One is Goldman, either 2 mirror, 3 mirror, single mirror, or everything is possible. We discussed Goldman 3 mirror and slit lamp by microscopy. So one of the mirrors is to see the angle. Then Zeiss, Yadrikos, Zussman and Posner-Rich. You have to be only familiar with the names. Don't try to learn everything. You will know it. But if I have to do a surgical procedure like goniotomy, right? Or I have to go for trabeculectomy. So is a small child, especially when I am operating in the angle, mainly in the goniotomy, what we will do, we generally use Coppes or Swan-Jacob. What? This is not through reflected, it is telling. So that means what? Practically it means, if I am doing a gonioscopy, as you saw that patient was examined in the OPD, it is generally through indirect gonio lens, which means whatever upper structures I am seeing in the angle is actually of the inferior angle. So it is always reverse because it is through reflected light. This is what we have to keep in mind. Nasal is temporal, temporal is nasal and so on. But when I am looking at from the direct, which are the direct ones? Coppes and Swan-Jacob. Then mainly used during surgeries. So this time, if I am looking at the superior, I am looking at the superior. Okay? So just know this. And how do you document the gonioscopic finding? Again, we make two crosses like this. And whatever superior, but we have to remember that we have to reverse it because we are looking opposite. And then we can say which structures I can see in this quadrant, nasal, temporal and inferior. I can mention that. We can also comment on the pattern of the iris. Okay. And if I am doubtful about whether there is synechia formation or not, synechia is what? Adhesion between the cornea and the iris. Then I can go for indentation gonioscopy. I will press a little bit and do to see whether the angle is opening on pressing or not. If it is opening, means adhesions have not formed. If it is not opening, then there can be adhesions. Okay? That's all about gonioscopy. So we know what is the principle, what are the structures seen, right? And how to record. Okay? So you can say how to, it is inverse view and we record like this. Whatever I am seeing the structures. I am seeing till only Schwalbe's line is seen, or I can see even scleral spur and so on like this. Okay. So once we know this, so this is one important thing. As we have talked about occludable angles. Yeah, this one. So these are the adhesions. Look at this. So between the iris and cornea, this is what is peripheral anterior synechia. So what will you do? Indentation gonioscopy. We will see that even with the indentation gonioscopy, this is not going to move. I cannot see the angle structures. That means it is a synechia or adhesion. Okay, then we talk about the next is here. What is this slide showing you? We are seeing blood vessel in the angle. Okay, so here you are looking at the neovascularization of blood vessels in the angle structures. So there can be these pathologies which can also be seen through whenever you are doing the gonioscopy. Okay, we'll now talk about that whatever gonioscopy or angle structures that you are seeing. How do you grade the angle? Now there are actually many ways of grading like Ski's method, Spieth method, Schaffer's method. We will just take Schaffer grading, and that is just for the sake of it because again in my all these more than 21 years of experience of teaching for the PG entrance, I have not seen a single question on grading. So I am not going to take too much time discussing all the gradings. We will just talk about one of them. This is Schaffer's system of grading. So what you do before you understand this, you have to first understand this one. So what is the Schaffer system of grading telling us? We are taking the angle in degrees between two imaginary lines. What are the imaginary lines? One is tangential to inner surface of trabecular meshwork and anterior surface of the iris. So angle, now you look at this one. It is the angle between the trabecular meshwork and the iris. So what will happen if the iris is in normal position? It will be open up to grade 4, 45 degree. But as there is push or pupillary block and iris is going anteriorly, it can keep on decreasing, right? So when it keeps on decreasing, the angle structures that we are seeing will be different in each case, isn't it? On gonioscopy. And this is totally closed. I can't see any angle structure. This is only iris. So what are the angle structures seen? And how do we grade it? We can see from this chart. So if you don't invest too much time in learning, understand what is Schaffer's and a basic thing. So whenever the angle between these two tangential line is around 35 to 45, we will grade it as grade 4. It is wide open. We will see up to ciliary body, arms. But if I am not seeing the ciliary body band, I am only seeing up to scleral spur. That means it's still open. SS scleral spur still open up to, you can say 20 to 34, whatever helps you to learn, you can learn this. Then if, okay, not scleral spur, I can see only till trabecular meshwork, then it is now a narrow angle. It becomes grade 2. If I am only seeing Schwalbe's line, it is extremely narrow, this is grade 1. No structures visible, the angle is closed. Okay, so this is how we grade the angle on gonioscopy. Okay, this was one way of assessing the angle. What was the other way? You have seen the list, that was Van Herrick's method. What is a Van Herrick's method? Van Herrick's is saying that we are actually seeing let us look at this one, the ratio of anterior chamber, so peripheral anterior chamber depth and the corneal section. If this is the slit lamp, so this is, you are looking at a black space and this is the scatter of iris. So this is the anterior chamber depth and this is the corneal thickness, right? So we are actually looking at the ratio, okay? So width of the empty space as compared to the cornea. This is the empty space you are seeing, black empty space, optical space. This is the depth and this is the corneal. What is the ratio of that space to the corneal thickness? So that gives me some idea, in a quick idea in a slit lamp, okay, this angle will close or it is closing or whatever is the angle status. Again, if you look here, if the limbal anterior chamber depth, peripheral or limbal anterior chamber depth, no black space is there, that definitely common sense, if there is no space between these two, it is closed, isn't it? Okay. And now when the space is little better but extremely narrow, we consider it grade 1. Okay, that should be, what you have to remember, that this space is less than 1/4 of corneal thickness, or is it equal to 1/4 of corneal thickness, or is it more than 1/4 to half? And equal to will be wide open, almost more, equal to is, okay. So this is how we are. Again, don't put too much time in learning the grading. It has not been asked till yet, but we are just preparing ourselves for some surprises as well, right? So that is a Van Herrick grading. And then I also told you about ultrasound by microscopy, right? And we had, okay, this is another slide which we did not talk about is, this is the plateau iris and this on gonioscopy showing the angle closure. Okay, so ultrasound by microscopy and ASOT, OCT, right? So these are the angle chamber, anterior chamber angle assessments that we will remember as of now. Now let us talk about clinical features. We will learn the clinical features, how the patient presents according to, give the heading, staging according to natural history, classification according to natural history. All of you give the heading? Yeah, so let's talk about, it starts with, first is PACS, means primary angle closure suspect. So staging according to, give the heading, staging according to natural history. Right? So first would be PACS, primary angle closure suspect. This stands for, so this is a patient whom I see more than 3 quadrants of ITC. What is ITC? On gonioscopy, ITC stands for iridotrabecular contact. Did I not talk about this? This is what is occludable angles, right? I cannot see post TM, right? So occludable angles, that is, or you can say the ITC is nothing but occludable angles or iridotrabecular contact. of more than equal to 3 quadrants on gonioscopy, then he is a suspect. But when I am looking at the other parameters, IOP seems normal. And okay, just let me finish the angle part. There is no peripheral antiasynekia. No peripheral antiasynekia, and intraocular pressures are normal, right? But what I am saying, he's a suspect. He is at a risk of developing, or she is at a risk of developing this glaucoma. So when I look at mainly when I am looking at the lens iris, let me show you, lens iris diaphragm. So when I am looking at the lens iris diaphragm, it is convex. Because of that, if the lens iris diaphragm is convex, what do you see? There will be some shallowing of anterior. So what is happening here? If I am showing, look here first. If I am showing this torchlight from one side, okay, at the angle, what I see is a dark shadow on the opposite side because of more convexity of the iris. And this is called eclipse sign. Look here. This is how I am examining this patient, right? When I am examining through the torchlight, what I see, that one half here there is light is not reaching. So it's a narrow angle. The light is not reaching. But if the light reaches from here to here, yahan bhi aa rahi, yahan bhi, then it becomes a normal angle. So this is what is called eclipse sign in PACS. Okay, so these are the findings of PACS. How will you manage? If I see a patient that, okay, he has occlusive angles, I can go for prophylactic peripheral iridotomy. How do you do a peripheral iridotomy? With ND-YAG. So with ND-YAG laser, we go for peripheral iridotomy. When you do it with the laser, it's otomy. When we do surgically, it is called iridectomy. Okay, so that's the difference. So in both eyes, and we can also try to remove the factor of the lens and increase lens vault by taking out the lens. That is lens extraction. Then what would be the next stage? The patient was suspect. Now he is going to be primary angle closure. There is definitely a closure. If there is a closure, again I am seeing the occlusive angles in more than 3 quadrants. ITC in more than 3 quadrants. Note down please. And of course, this time my peripheral antiasynekia may or may not be present, which I can confirm by indentation gonioscopy. But intraocular pressures I am getting is high. And because the intraocular pressures are high, I am keeping it as primary angle closure. Management is same. Go for prophylactic peripheral iridotomy. And if the pressures are high, I should be controlling the intraocular pressures. I want you to note down everything. Okay? So we will say this time the iridotrabecular contact, I am writing for you, iridotrabecular contact of more than 3 quadrants, plus minus PAS. PAS is peripheral antiasynekia, raised intraocular pressures, and how to manage the intraocular pressure and do a prophylactic PI. What would be the next stage? Okay, don't look at this. The next stage would be primary angle closure glaucoma if it proceeds. But then there is some in between, there can be some acute attacks, and that is what is called acute primary angle closure. Right? When you say acute primary angle closure, we are talking about acute congestive glaucoma. Okay? So we are talking about acute congestive glaucoma. So what happens in acute congestive glaucoma? This is the stage where this all 360-degree angle gets closed. We'll write everything, just understand. When all 360-degree angle gets closed, definitely IOP is going to rise too much. It goes up to 16 mm of edging. Such a high IOP causing a lot of pain associated with nausea, vomiting. Okay, so we are talking about acute congestive glaucoma, or now the latest term for this is acute primary angle closure. Okay, so this is what we will call it. Why will this patient have? Suppose he is a patient of only primary angle closure, which we just discussed. Any precipitating factors, darkness, prone position, if you are dilating the pupil, I discussed this with you already, any emotional stress, all these, and of course medications. Please write it down. This was a little quick, but I want you to note it down. What are the precipitating factors? Please write down darkness, prone position. These are the basis of provocative tests, right? We go for dark room prone test, make the patient lie prone in the dark room for 1 hour. So that is DRPPT, dark room provocative prone test. Provocative provocative test. Then mydriasis again has been one of the ways of doing the provocative test, and we know it can precipitate angle closure. This is not difficult. Emotional stress, that fits everywhere. I hope you have noted down. Now pay attention. Very important. This is your exam question. And they have asked you about topiramate. Okay, make a cue here. So topiramate actually causes edema or effusion in the ciliary body, and this is the cause of precipitating angle closure block. Okay, so this all can also lead to angle closure attack or acute primary angle closure. Make a cue there, all of you. Any sympathomimetic, why? Again, this will cause any systemic, we are talking about here, systemic medications. Because this will again cause dilatation. It can cause dilatation, either topical or systemic, and that can lead to acute primary angle closure. Okay, stage. Acute primary angle closure stage. Now we talk about clinical features. Now, clinical features, let's draw a diagram and then learn the clinical features of acute primary angle closure. As I said, this is actually a case of painful red eye, right? All 360-degree angle is closed. Because of that, what is happening? The patient is presenting with redness, photophobia. We all know what is photophobia? Intolerance to even normal light. And blepharospasm. What is blepharolids? Spasm means closing of the eyelids. So because of photophobia, there will be blepharospasm. We talked about such a high pressures can go as high as 60 mm of mercury. Let us note down 60 mm of mercury. And what else we will understand here is lot of pain. Pain is so much that it is associated with nausea and vomiting. Pain is associated with nausea and vomiting. What will I see on examination? Let's make a diagram. On examination, outside twins start thinking. Corneal edema. Why? Because of such high pressures. Have we discussed this earlier also? That the basic stromal pressure in the cornea is anything around 53 to 55. And normally it should be more than IOP. When IOP increases than stromal pressure, there is corneal edema. And if you remember your lens chapter, this is the cause of colored halos. Right? Of course, what else I will see? Shallow AC. We are talking about features of acute congestive glaucoma, which is now called acute primary angle closure. Shallow AC. Angles, what should I write here? Closed. All 360-degree angles closed. Don't say narrow. What should I write for the pupil? Again discussed. Mid-dilated. Maximum closure occurs in mid-dilated pupil. Learn with me. It is vertically oval mid-dilated. Why vertically oval? There are two theories. Attack has led to some iris atrophy, but most important and reason for vertically oval that you should know. This is the normal process of dilatation of your pupil. Whenever you are going to put the eye drop in your eye also, any mydriatic, it first becomes vertically oval and then dilates. And what has happened here? It has stopped at the mid-dilated. So it is fixed, it is non-reacting, it is vertically oval. Right? Any other finding? What about cupping? Should I expect that? So if this patient has a recurrent attack, I can see some changes in the disc. But cupping or changes in the fundus changes in very acute attack may not be appreciated. Okay? Now once this attack is over, right, then what are the features of a resolved acute primary angle closure? How will I know this patient has attack, or maybe he has or she has suffered more than one attack of acute congestive glaucoma? Okay, before I come to the next heading, what will you do in this case if this patient has such a high pressure? How do you open the angle? We just discussed constricting the pupil. Should I start giving pilocarpine in this patient immediately? No. Exam question, very important. What is the treatment of choice of acute congestive glaucoma or acute primary angle closure? We will say we have to go for first decrease the pressure. So our answer will be either IV mannitol or acetazolamide. Once the pressure, why? Why? Because it's such a high pressure, there's ischemia in the iris. And when the iris is ischemia, it is not going to react to any drug, whatever you are putting, whether pylo, whether anything else. So just first decrease pressure. Once you decrease the pressure, of course we will start pilocarpine simultaneously, then only it will react and this will respond. The patient will respond and the angles will open. Okay? So keep this in mind, right? Okay, first see this slide. So we are still in acute congestive glaucoma or acute primary angle closure. What are you looking here? Lot of edema. Okay? You look at the pupil. Can you appreciate? So this is a red eye. Redness can be appreciated. Then which type of congestion is this? Glaucoma. It's a ciliary redness or ciliary congestion. Right? What is the other type? Conjunctival, right? So this is one. Then we can see the pupil is vertically oval. We just discussed that. I can see the haze and corneal edema here. Okay. So these are some findings of course, we will see that the patient is a lot much in agony and pain. Of course, all those things will be there. We have discussed that. I was talking about IV, mannitol, we give pilocarpine. What else? Let's add a few more things. Like if there is a lot of inflammation, I may start with topical steroids, but I have to be careful. Steroids are a problem themselves for the IOP. But yes, in acute stage, I may give. And 10% glycerine for corneal edema. So wherever you have written the treatment, let's add, I may need 10% glycerine, topical glycerine for corneal edema, right? Or edema, generally hypertonic saline solution is also given. And this in your treatment part, please add this, topical steroids to control inflammation. And lens extraction may be considered. That helps to prevent this angle closure. I've explained you already, right? Okay, now we will talk about resolved case of acute congestive glaucoma. Please again make a diagram and label it, you will learn it. So resolved case, again if we draw here, what are the things? If there's a corneal edema and there was high pressures while it is resolving, I can see some descent membrane folds. I want you all to please draw the diagram and label, then you will remember. Don't write in a list, it's difficult to learn. Then second, of course, iris atrophy. Because of this high pressures, there is damage. Pupil will be irregular, right here. There can be cataract, right? And now I may see cupping of this, plus minus, right? I may or may not. Again, if there is substantial damage because of some recurrent attacks, I may appreciate. Now on the lens, very, very important, these are epithelial infarcts and we call them glaucoma flecken. This will again happen because of an acute episode of high IOP. Okay, so this is your glaucoma fleckens. Please make the diagram and label it. You will learn what is resolved acute primary angle closure. Now, so I shouldn't forget it, therefore I have written it here only. Vogt's triad, very, very important, make a cue. What is a Vogt's triad? Vogt's triad will be the findings, that is dispersion of pigment on the cornea, okay, so this could be just like KP sinus dispersion on the endothelial layer. That is what it is. Second is glaucoma flecken, which I have explained you is nothing but infarcts, epithelial cell infarcts. And third in triad is iris atrophy. Okay, so any triad of this is indicating that this patient has got multiple attacks of acute congestive glaucoma. Okay. What would be the next stage? Okay, this slide. First see this slide. This is your glaucoma fleckens. Next, as I said, this patient will progress into PACG. So it was PACS, PAC and now PACG. Again, our angles are occludable. I am getting a peripheral antiasynekia. IOPs are high. I also get fundus changes. There is damage of the optic nerve. Simple, easy. So when there is damage of the optic nerve, now I have to use the word glaucoma. So now this is PAC. So what are the stages we have discussed? Again quickly revising so that you can learn with me. It was primary angle closure suspect, then primary angle closure. Then we talked about acute primary angle closure, which is nothing but acute congestive glaucoma, right? Then what will be a resolved acute primary angle closure present as, right? So you can see here, we have already made the diagram and written why you are getting an irregular pupil. Irregular pupil is because of such high pressures of 60 millimeters of mercury, there is a damage of the iris sphincter. So mainly it is iris sphincter, it can be dilator pupil also, but mainly iris sphincter, because of which you are getting an irregular. Mainly learn like this, if the pupillary muscles are damaged due to such abnormal high pressures in the eye, that is one cause of irregular pupil, right? And why are you getting the DM folds? So DM folds are because again the pressure was very high, there was corneal edema, and now what has happened? Suddenly when you are initial treatment with an IV acetazolamide or an IV mannitol, the pressure drops down, that leads to Descemet's folds. Okay, so this is the cause of Descemet's folds. Glaucoma flecken, I think I told you, it is epithelial cell infarct. Okay, yes, and we can definitely get cataract and cupping can be present or not. We next talked about the stage of when PACG, which is now primary angle closure glaucoma, right? Where now there is optic neuropathy and we are getting the fundus changes. What next? It can be present chronically, right? So the next would be chronic glaucoma, which is we had learnt in our earlier staging as chronic congestive glaucoma. So what is chronic glaucoma? A very simple way of learning is, please write down all of you. Chronic glaucoma is nothing but we will learn like this, all the features that you have learned in open angle. What were the features in open angle? That means IOP changes, so I will be getting raised IOP in this patient. Then there will be fundus changes are present. This is the easiest way to understand and retain. Field defects, visual field defects are also present. And apart from that, when I do gonioscopy, I see angles are closed. Typically, we describe it as creeping angle closure. Slowly the angle is closing, we call it creeping angle closure. So when I see this patient with these findings, I am again going to assess the angle. Angle assessment, as we have learned, gonioscopy or by ultrasound by microscopy or OCT. Once you have assessed the angle, commonly we do gonioscopy anyways. So after this, another thing that I can do here is a provocative test, which I mentioned to you was dark room prone provocative test, DRPPT, right? So if this patient has come to me and I do a DRPPT, I'm putting the patient in a prone position for 1 hour in a dark room. If the difference of pressure is more than 8, this is what is significant, right? So any IOP of more than 8, now this is indication of treatment, it is significant, that means the test is positive, right? And if you see, okay, peripheral iodotomy is already done. So as you know, we have just learned the mechanism of angle closure could be either peripheral iodotomy, I mean to say pupillary block, right? Or it could be plateau iris. So either if it is more and if it is positive, the test is positive, I should go do a PI. But suppose the patient already has a patent PI, then the cause could be plateau iris. So if patent PI is already there, then this is the cause is plateau iris, okay? And in this case, what we are going to do, if the cause is plateau iris, it can be helped by removing the lens. Lens extraction should anyway be done in these patients to prevent any further angle closure, right? So it has been seen by the latest studies, these are all the latest studies, that lens extraction will help. So this is how we will manage this stage. Okay, so you have learned all the stages how we are managing. We didn't discuss how are we managing primary angle closure glaucoma. Of course, again, closure is managed by pilocarpine, right? And apart from that, definitely what we are going, if they ask you what is the choice of drug for angle closure glaucoma, PACG, our answer will be latanoprost. We will be discussing the anti-glaucoma drugs, which is another very important topic. So, if they ask you the treatment of choice or drug of choice of only primary angle closure means pilocarpine, I have to open the angle, there is no damage in the nerve. But if they ask you the drug of choice of primary angle closure glaucoma, now I can answer latanoprost. Okay, so this is how you have to answer for your MCQ. And which is the last stage? If the patient has all this, after chronic comes your absolute glaucoma. So what is absolute glaucoma? It is a painful blind eye, right? So absolute glaucoma means all the nerve fibers are damaged and there is 100% cupping, right? So when you say 100% cupping, so all the nerves, so the CD ratio becomes 1. So all the nerve fibers are damaged. The eye is described as stony hard. So just understand, this is a stage which is not responding to any treatment as well. Stony hard, why? Because the pressures are very, very high. Let's note it down. And it is a painful blind eye. Blindness because there is glaucomatous cupping. Pain because of the high pressures, right? How can you help these patients? The patient is so much in agony that the patient will say, just I want to get rid of this pain. I can't see through this eye. So generally this has been a very important exam question. Time to make a cue here. So they will ask you, what is the treatment of choice of absolute glaucoma? What is the treatment of choice of absolute glaucoma? Aim of treatment is to relieve pain, isn't it? We cannot just give vision to this patient. The nerve fiber damage is always irreversible. So to relieve pain, what is the treatment of choice? We are going to go for cyclotherapy, either through cryo or through laser, right? What we are going to do, I'll talk about this in detail in the treatment part as well. What is cyclotherapy? From where the aqueous is formed? Ciliary process, right? So ciliary process, if at the limbus is the angle, where is the ciliary body after that? So ciliary process area is anything around 2.5 millimeters from limbus. So at this position, if I put either laser or cryo, what am I trying to do? I am damaging some of the ciliary processes. So my aim is, in this patient, he is already not able to see anything, it's a lot of pain. How to control the pressure? It is a refractory stage, it is not responding to the usual treatment. So go for the damaging of the ciliary process so that the aqueous is formed less and the pressure is controlled. Okay? Now suppose you have been very over-enthu and you have over-treated the patient and damaged too much, almost all the ciliary process. I hope you are drawing and writing along with me. So if there is an over-treatment, now what will happen? Any over-treatment means if all the ciliary processes are almost damaged, no aqueous is formed. If no aqueous is formed, there is no pressure in the eye is going to shrink. It will shrink. So when the eye is shrinking, this blind shrunk eye is what is called, you must have learned this yourself as well, phthisis bulbi. So any over treatment can lead to blind shrunk eye, which is called phthisis bulbi. Can I do something else apart from cyclotherapy? Right? Yes, what I can do is, other modalities can be, you can relieve the pain by giving retrobulbar, means behind the eyeball. We discussed this in our cataract chapter, lens chapter as well. So retrobulbar injection of absolute alcohol. So if you give a retrobulbar injection of absolute alcohol, you relieve the pain. Why? Because it suppresses ciliary ganglion. It is just behind the eyeball. So the method is, it suppresses the ciliary ganglion. Okay? Please remember this, it's important. Now, if it suppresses the ciliary ganglion and therefore relieves pain, why is this not the choice of treatment? Why I am doing the cyclotherapy and damaging the ciliary process? This seems to be a simple method. I have to just give an injection. And anyway, the nerve fibers are damaged. I don't have to be very, very careful in giving injection also. There is no vision already. So, why this is not the choice of treatment? Have you thought of it? Because you have to give the injection again and again. So it will have some duration of the effect will be only for some duration, and again you will have to repeat the injection. But when I am doing a cyclotherapy, it's like a permanent, right? Very good. And if nothing works, what can be the other method? If nothing works, we remove the eye. What is that called? Evisceration. We will talk in detail in our orbit chapter, or enucleation, whatever, right? So generally either of it we can do, mainly it is evisceration. So remove the eye, right? So that was about absolute glaucoma. So we have been talking about peripheral iodotomy and how this is so important, whether it is a stage of PSCS, It is a stage of PAC. In both we are doing prophylactic, we should do in both eyes. This is also an exam question. Do we do peripheral iodotomy in one eye? No, we always do it prophylactically in the other eye as well. Or if I am doing anyway prophylactically in a stage of PACS or PAC, I have to do in both eyes, right? Because all the risk factors involve both eyes. Okay? The eye is small and shallow AC, narrow angle, family history. So please don't wait for the eye to suffer from acute congestive glaucoma. Every attack of acute primary angle closure means lot of nerve is damaged. Okay? I hope this is clear now. Right. So a few points about peripheral iodotomy. Peripheral iodotomy, where do you think you want to do that in the iris? So you are creating another hole in the iris, right? Do you not want to do somewhere where it can be covered with upper lid? Because another hole means it can lead to diplopia, right? It can lead to glare. Therefore, if I am trying to do a peripheral iodotomy, few points here, I should choose 11 to 1 o'clock position so that it is covered with the lids. Okay. Generally, we avoid exact 12 o'clock, but we can do from this to this. Second, another important thing is where do you want to do it? Thinnest part of the iris. So we will say we generally hit at the crypts of the iris. Okay, which is the thinnest part. Right. So if we know this much, of course we already know about which laser is used. It is Nd:YAG. This is most important. We are using Nd:YAG laser for peripheral iodotomy. When I am focusing the laser, do I need any lens? Yes, it's better to use a lens. Which lens I can use? Okay, I can go for Abraham lens. Now this is, guys, this is your exam question. Abraham lens. Make a Q. Put a Q here. So Abraham lens is 66 diopters, or I may even use a Wise lens. Wise lens. Abraham has been an exam question. This is 103 diopters. Okay? I want to use the lens so that the laser energy is not going into the cornea or in the lens adjacent structures. I am focusing only where I need it. Right? So that was about peripheral iodotomy. Okay, so see, this is your Abraham lens. This is the peripheral iodotomy which has been done in this patient. Look at the location, right? So, yes, please remember you want to constrict the pupil so that you can get a nice iris periphery for doing the laser. So, always use pilocarpine before doing the laser. Right. Okay, so let's talk about secondary glaucomas. First of all, we have learned the classification, a little detail here about secondary glaucoma. What did we learn? It can be either open angle or angle closure. Let's divide like this: open angle and angle closure. Okay. Then we have talked about open angle can be further divided as it can be pre-trabecular, the cause is before the trabecular meshwork. It can be trabecular or it can be post-trabecular. Hope you are noting down here. So when you say pre-trabecular, what can be the causes? What are the important ones we have to know? Neovascular glaucoma. Then second very important, ICE, iridocorneoendothelial syndrome. There has been question on both of these topics. We will deal this in detail. And or it could be just epithelial ingrowths. Epithelial ingrowths means they are ingrowth into the angle, and later we are growing into the angle structures, right? But here per se trabecular meshwork is blocked, then it comes under trabecular cause. Okay, na? So don't mix it up. Trabecular cause we will learn. First is pigments, as in pigmentary glaucoma. So one is pigmentary glaucoma. Second will be pseudo exfoliation syndrome. Very, very important. We will learn this, right? Third, it could be just uveitis, means it is the inflammatory cells which are blocking, right? Then I'm still talking about the trabecular cause, which was number 3 ho gaya na? Okay, so next could be hemorrhage, any hyphema which is later causing the RBCs to block the trabecular meshwork. It could be hemolytic, hemosiderotic, that is iron, due to iron, okay, or it could be when the macrophages are engulfing and that is blocking. So anything, so just let us broadly write down due to hemorrhage or hyphema. Then what is phacolytic? We all know. Again, it is the lens material which is blocking the trabecular tissue. What is post-trabecular? So post-trabecular, let me write here only. So post-trabecular means what can be the causes? After the trabecular meshwork, where is the aqueous going? Episcleral venous system. So all the causes of increased episcleral venous system, venous pressure. All the causes of increased episcleral venous pressure. Right? So from there, episcleral venous system, superior inferior ophthalmic vein going to the cavernous sinuses. So what could be the causes of increased episcleral venous system? Start thinking from there. Carotico-cavernous fistula, CC fistula, number 1, isn't it? What else is very important for us to learn is Sturge-Weber syndrome. Sturge-Weber syndrome. Right? And of course, even thyroid disease. Thyroid eye disease. Now, I don't want you to mug up the list or anything. It's just for your understanding about the classification. Let's also consider angle closure. So, when you talk about secondary angle closure, let's write this also. So, angle closure, what did you learn? With pupillary block and without pupillary block. So, when you say with pupillary block, I think we all know about phacomorphic, isn't it? Or phacotopic glaucoma, which is due to dislocation of the lens. This is phacotopic. Right? Or any uveitis which is leading to, I'll discuss this in uveitis chapter, which is causing seclusio pupillae. Seclusio pupillae is nothing but ring synechia, where the whole pupillary border is sticking to the lens and blocking the pupil, and again it is the same story. Aqueous cannot come forward. So seclusio pupillae. Okay, this is your with pupillary block. And without pupillary block getting an angle closure, it could be, we can say, again ICE syndromes will fall into this, okay, ICE syndrome. So, there is some fibrotic change happening with due to the contraction of that, there is closure of the angle, okay? And also in advanced cases of neovascular glaucoma where there can be peripheral anterior synechia, then this is also considered in. Things seem to be little overlapping, you know, which means that the same IC syndrome which we were learning as a pre-trabecular cause, there we are also learning as a angle closure. So, it is initially open angle maybe and later it becomes angle closure. Understand? So, that is why you have written it at 2 places. Okay, so that was about the classification. We will first start with pigmentary glaucoma. A lot of findings, interesting findings. What is pigmentary glaucoma first? Pigmentary glaucoma, you know, it's a simple story, is that pigments from the, you know, the posterior-most layer of the iris is pigments. So, there is some chaffing in the iris and the pigments are released. Please make this diagram. From the iris, this release of pigments into the aqueous humor, where common sense, it is going to flow into the angle, block the trabecular meshwork, and hence lead to secondary open angle glaucoma. I hope you have made the diagram, right? So, what is this? What is the story is understood? It is a pigment dispersion from the iris, flowing through the aqueous, blocking the TM, causing open angle glaucoma. Now, generally, what are the other points you know? When this pigment is deposited, we have some interesting findings which are important. First, think yourself, if there, I'm going to show you the slides, you will be absolutely clear, but first listen. If there are no pigments here, light is going to pass more through it. And this is what is called trans-illumination defects. Common sense? I'll just show you what it means. More light is passing because pigment blocks the light. No pigment, so light is passing more. Number two is pigments at the back of the cornea. These are any deposit at the back of cornea is what? KPs. And these are also called Krukenberg spindles. These KPs are spindle shaped, we call them Krukenberg spindles, right? Okay. What else you can see? When I am going to see the gonioscopy, I will see pigment deposition there in the trabecular meshwork. A dense deposit of pigment in the angle. So I can just mark here as angle, please label it. In the angle, there can be dense deposition of pigment on trabecular meshwork. Deposition of pigment on the trabecular meshwork, right? Okay, so let's talk about what is this slide showing you. More light is passing because the pigments are all dispersed. This is what is trans-illumination defect. Trans-illumination defect. See, this is the heavy deposition of pigment on the trabecular meshwork seen on gonioscopy. This is the stripe of pigment on that, or we are calling it, these are the KPs, which are called Kuchenberg's spindle. Right? We can see that. You can appreciate this. These are the KPs. And when I am doing an ultrasound by microscopy, what I see this time is a concave configuration of the iris. And you know what is the interesting part? That is why pigmentary glaucoma is also called reverse glaucoma. This time the direction of the iris is reverse. It's not a Bombay, it's reverse. So it's a reverse glaucoma. Can we note this down? Right? And do you realize if it is concave, it will rub against the suspensory ligament, and that is the reason for release of pigments. Okay? Now you got it? Okay. So this slide is making things more clear. What are we looking at? Yeah, this is what I was trying to show you. Next was this. So at the equatorial area, here in the lens, near the where the suspensory ligaments are attached, right? So we see this any pigment dispersion at this equatorial area, right? Near the, so this is near the zonular insertion. This is called Ske's strips. There are two names. We can learn both. Either you can call it as EIE, skies. Let me write it. Or more commonly we can call it Zentermeyer's line. Now this one has not been asked in an exam, right? But they have asked you about trans-illumination effects, right? So just let us remember all the findings, okay? Yeah. So here I can see if this is the section of the cornea, I can see the pigment deposition. These are the Kuchenberg's spindles or KPs, which we have just learned. These are the KPs. Again, it is heavy deposition of pigments on the trabecular meshwork, right? I remember one more thing. I think they have asked this. Yeah, see, this is a very good slide to show you the Zentermeyer's line. Okay. Now, apart from this, they have asked you about what is Sampolesi's line. So, you know what is Sampolesi's line? It is again an extra pigmented line anterior to the Schwalbe's line, which can be seen in both pigmentary glaucoma as well as in pseudo-exfoliation syndrome. So, this is nothing but anterior to Schwalbe's line. You all know what is Schwalbe's line now, isn't it? It is the Descemet's membrane of the cornea seen in the gonioscopy. So, Schwalbe's line, anterior to the Schwalbe's line, this is the pigment line of pigments deposition. Okay? This is what is called Sampolesi's line. It can be seen in both, write down, pigmentary glaucoma and pseudo-exfoliation syndrome. It is seen in both pigmentary glaucoma and in pseudo-exfoliation syndrome. I think we are over with the findings, but okay. And once we know what are the findings, and we have already learned here that what is actually happening in pigmentary glaucoma, correct? Let us learn one or few more things. It is more common in males and mainly young myopes, okay? So, this is important. So, let us note down, pigmentary glaucoma is more common in young myopes, and there is a predilection to male gender in males. And generally you see the histories after exercise or something, after coming out from the gym. Now what has happened? There is a lot of pigment dispersion due to this, and that has precipitated in increase of intraocular pressures. Okay, so that's a very common history. This is also called reverse glaucoma. We will learn about inverse also. So remember, this one is reverse, where there is a concavity in the iris. Done? So apart from the medical, the treatment would be anti-glaucoma drugs. All the medical therapy you can give with anti-glaucoma drugs. We will be talking this very soon. And second, what you can go for is argon laser trabeculoplasty. It has been seen that this argon laser trabeculoplasty, so what are you doing here? You are putting, argon laser is a photocoagulative laser which you are putting on the trabecular meshwork, right? So this helps in opening of the trabecular meshwork, right? So argon laser trabeculoplasty, whenever we use a photocoagulative, we call it a plasty. And it is seen that in pigmentary glaucomas, it is quite effective, more effective in pigmentary glaucomas. Okay, so that was so in detail what you have to learn first was pigmentary. The next one, which is very, very important, is pseudo-exfoliation syndrome. Pseudo-exfoliation syndrome. Right? So before I go to the details of pseudo-exfoliation syndrome, a very important cue that we can note down here, this is the most common secondary glaucoma. It is the most common secondary glaucoma.